So we shall start discussing about the trigeminal nerve and the examination of the trigeminal nerve. So trigeminal nerve is the largest cranial nerve. We should know that the trigeminal nerve is the largest cranial nerve. It is the largest cranial nerve in human body. So it is a mixed nerve, which means that it has both function, sensory as well as motor. Sensory means it carries the sensation, pain, temperature, touch, 2-point discrimination, proprioception. That is the sensory function, as well as it has the motor function. It gives the motor supply to the muscles of the mastications, that we chew food, the muscles of the mastication, the masseter, the temporalis, the pterygoid muscle. So it carries sensation from the face as well as it gives motor supply to the muscles of the mastication. So it is a mixed nerve which has a sensory function. It carries sensation from the face, the forehead, the cheek, the lips, the chin, everywhere. The trigeminal nerve carries sensory function or the sensory input to the central nervous system, and it gives motor supply to the muscles of the mastication. So what are the muscles of the mastication? The temporalis, the masseter, the medial and the lateral pterygoid. The temporalis muscle, masseter, the medial pterygoid and the lateral pterygoid muscle. So remember, the temporalis, the masseter and the medial pterygoid closes the jaw. It closes the jaw. So the jaw closer is the temporalis, masseter and medial pterygoid, and only the lateral pterygoid opens the jaw. So lateral pterygoid opens the jaw, whereas temporalis, masseter and medial pterygoid, it closes the jaw. And the masseter, medial pterygoid and lateral pterygoid protrude the jaw, ऐसे बाहर की तरफ जो निकल रहा है. Protruding the jaw is the function of masseter, medial pterygoid and lateral pterygoid, and the temporalis retract the jaw, अंदर की तरफ जो जा रहा है, that is the retraction of the jaw is done by the temporalis. So the jaw opener, the jaw closer, the jaw protrusion and the jaw retraction. You should know that these are the function of the muscles of the mastication. So what will happen if the patient is having unilateral pterygoid weakness? So if the patient is having weakness of the, say, suppose right side of the pterygoid muscle, the medial pterygoid and the lateral pterygoid on the right side is weak. So when the person will open his mouth, if suppose the right side there is weakness of the medial and the pterygoid muscle. So when the person will open his mouth, you can see the jaw will deviate towards the side of the weakness, which means if the weakness is on the right side, that the pterygoid weakness is on the right side, the medial pterygoid and the lateral pterygoid, there is weakness on the right side. So when the person will open the jaw will deviate to the right side. So there will be deviation on the side of the weakness, So remember, the normal function of the pterygoid is to deviate the jaw on the opposite side, but if there is weakness on this side, it cannot deviate the jaw on the opposite side. So there will be unopposed action of the normal side which will push the jaw towards the abnormal side. So if the patient is having weakness on this side, jaw will deviate on this side because of unopposed action of the normal side. There is no normal muscle here which is opposing the action of the other side, so jaw will deviate on the same side. So these are the muscles of the mastication, the temporalis, masseters and the medial and the lateral pterygoid muscle. The lateral pterygoid muscles open the jaw and the other muscle closes the jaw. The other muscle which are supplied by the trigeminal nerve are the mylohyoid anterior belly of the digastric muscle. These are the muscles on the floor of the mouth, the mylohyoid and the anterior belly of digastric, and two tensor muscles, tensor tympani and tensor veli palatini. So these are the muscles which are supplied by the trigeminal nerve. So we have discussed the motor supply of the trigeminal nerve. So how do we check the motor supply of the trigeminal nerve? We will discuss how to check for the individual muscle in the later section of this video. So remember, the motor function of the trigeminal nerve is the muscles of the mastication as well as the mylohyoid, anterior belly of digastric, and two tensor muscle, tensor tympani and tensor veli palatini. So let us discuss about this trigeminal nerve, which is the largest cranial nerve, So starting from the Gasserian ganglion. So here is the Gasserian ganglion, Gasserian ganglion, or also known as trigeminal ganglia. So this is your Gasserian ganglion and the trigeminal ganglia. So you can see that from the trigeminal ganglia there are three branches. We know there are three branches of trigeminal nerve which arises from the trigeminal ganglia. So these are the ophthalmic branch, mandibular branch and the maxillary branch. Ophthalmic branch, mandibular branch and the maxillary branch. Also trigeminal nerve is also known as fifth cranial nerve. So this we can say ophthalmic branch is the first branch, V1, V2 mandibular, and V3 that is the maxillary branch. Maxillary and the V3 is the mandibular branch. So there are three branches of this trigeminal nerve: ophthalmic, maxillary and mandibular branch of this trigeminal nerve, which will supply the different area of the face, which will carry sensation from the different area of the face. The ophthalmic branch will carry sensation from the forehead, upper part of the nose on the lateral side, both upper parts of the nose, upper eyelid, and the maxillary division will carry the lower eyelid, the chin and the upper lips, and the mandibular division will carry from the lower lips, chin and the lower lips. Only the angle of the mouth is not supplied by the trigeminal nerve. It is supplied by the cervical nerve, C2 supplies the angle of the mouth. Just a little part here is supplied by the C2. Otherwise all part is supplied by the trigeminal nerve, the ophthalmic nerve, the forehead, the maxillary and the mandibular. So these are the sensory supply via these three sensory branches from the ganglia, that is the trigeminal ganglia. Then this trigeminal ganglia will have a root, that is the root of the trigeminal nerve, which will go inside the brainstem, to merge with the tree nucleus. So remember, the trigeminal nerve has three sensory nucleus. First is in the midbrain. Can you see that this is the midbrain, this is your pons, and this is your medulla. So in midbrain there is nerve, that is the nucleus of this trigeminal nerve is in the midbrain is known as mesencephalic nucleus. Mesencephalon is the midbrain, so the nucleus is the mesencephalic nucleus of the trigeminal nerve. You can see mesencephalic nucleus of this trigeminal nerve. And in the pons is in the principal pontine nucleus. This is the principal. In the pons, principal pontine nucleus, and in the lower part here you can see that there is the spinal nucleus, which is extending up to the upper part of the cervical spine. Can you see it is coming from the medulla and going up to the upper part of this is your spinal cord. So upper part of the spinal cord. So this is known as the spinal nucleus of trigeminal nerve. So there are three sensory nucleus of trigeminal nerve: the mesencephalic nucleus, the pontine nucleus, and the spinal nucleus of trigeminal nerve. So the root or the sensory root will go inside the midbrain and will supply both this mesencephalic nucleus, this pontine nucleus, as well as this spinal nucleus of the trigeminal nerve. But remember, the spinal nucleus of the trigeminal nerve will get the fibers only for the pain and temperature. only for the pain and temperature. This is spinal nucleus. As sensory input whole, it means touch, pain, temperature, 2-point discrimination, everything. But the spinal nucleus will get the fiber only for the pain and temperature. Mesencephaly will get for the proprioception. It will get the fiber for the proprioception. The touch will go in the pontine nucleus. So this is the organization of the nucleus in the brain stem: the mesencephalic nucleus, the pontine nucleus, and the spinal nucleus of the trigeminal nerve. And where is the motor nucleus then? These are the sensory nucleus. So here you can see this is the motor nucleus. This will come out of the central nervous system, go along with the V3, that is the mandibular branch, mandibular sensory branch, and it will supply the muscles of the mastication, as well as the other muscles that are anterior belly of the digastric, to the two tensor muscles and the two muscle mylohyoid and anterior belly of the digastric in the floor of the mouth. So this is the organization, and from the nucleus the fiber will ascend upward. The second order neuron will ascend upward. So you can see it will ascend upward from the spinal nucleus, everything, and it will go into the ventro-posteromedial nucleus of the thalamus, where there is sensory input. So remember, all sensation in our body goes to the thalamus first, except for the olfaction. We have discussed this in the olfactory nerve also, that the all sensation from the body, from the lower limb, abdomen, thorax, everything, from the face, all sensation, touch, pain, temperature, 2-point discrimination, taste, everything goes to the thalamus first before going to the cortex. But only the olfaction does not go to the thalamus, it directly reaches the cortex. So here the sensation from the face will go to the ventro-posteromedial group of nucleus in the thalamus, and the other sensation from the body goes into the ventro-posterolateral group of thalamus, but the sensation from the trigeminal nerve will go to the ventro-posteromedial group of nucleus, and then it will project up to the subcortical region. So you can see this is the organization of the different nucleus in the brain stem. The tract which is formed here is known as the spinal tract of trigeminal nerve. The pain and temperature tract which is coming and merging with this spinal nucleus is the spinal tract of trigeminal nerve. So this is the organization of the nucleus in the brain stem. There are 3 sensory division: V1, V2, V3, ophthalmic, maxillary and mandibular division, 1 motor root coming out and supplying the muscles of the mastication. So here you can see the ophthalmic division is supplying the forehead and the upper and lateral part of the nose. The maxillary division is supplying the chin and the upper lips, and the mandibular division is supplying the cheek and the upper lip. The maxillary division, mandibular division is supplying the chin as well as the lower lips. Only a small part here at the angle of the mouth is supplied by the cervical segment of the spinal nerve. So this you can see here. And one more important thing to remember is that onion skin type of sensory loss. What is onion skin type of sensory loss? Remember that the upper lips, the mouth and the tip of the nose, this part, the upper lips, the mouth and the tip of the nose, is the sensation from the upper lip, mouth and tip of the nose. Only the pain and temperature sensation from the upper lip, tip and mouth of the nose is present in the nucleus of the spinal tract. We know that the pain and temperature sensation goes in the spinal nucleus of the trigeminal nerve, but it is located medially. What I mean to say here, if we look at this spinal nucleus, so this is your spinal nucleus, So the sensation from the middle part of the face, the sensation from the middle part of the face, that is the face, the upper lip, the tip of the nose, upper lip and tip of the nose, the middle part of the face is located in the middle of the nucleus, middle of the nucleus. And the sensation from the lateral part of the face, that is near the ear posteriorly, is located on the posterior, on the lateral side of this nucleus, So remember that the patient's organization of the sensory system for the trigeminal nerve, the middle part is in the middle of the nucleus, and the posterior part or the lateral part is on the lateral side of the nucleus, Why it is significant? It is significant because if the patient is having, so hind face, the lateral part is located laterally, caudally. So if the patient is having selective involvement of sensory loss, say suppose the patient came to you and there is sensory loss, pain and temperature loss only on this upper lip, tip of the nose, upper lip and tip of the nose or surrounding area, the lateral part is normal, but there is only sensory loss in this part, which means there is some pathology in the middle of this nucleus, So if the patient is having syringobulbia, so dilatation of the syringe, dilatation of the cavity in the brainstem, so there is a cavity inside the brainstem normally. So if the cavity start to dilate, first it will affect the medial part, the middle of the nucleus, the medial part of the nucleus, and there will be sensory loss in this area. So if the patient is having sensory loss only in the middle part, then we can assume that the patient might having some pathology which is originating from the middle part of the spinal cord and going laterally, It can be syringobulbia, syringomyelia, dilatation of the central canal of the spinal cord, or central cord syndrome, or neurosyphilis, which selectively involve the middle part of the nucleus and middle part of the spinal cord, So that is the perioral sense region. There is first involvement, that is known as onion peel type of sensory loss. Only this part is involved, then the patient will have this part involvement, this. So there will be one layer will come out, and there will be involvement layer by layer because of the topographical arrangement of the sensory fiber in the trigeminal nucleus. So this is known as onion skin type of sensory loss, layer by layer. Then we should suspect that the patient might have some pathology which is originating from the center of the brainstem or the spinal cord. Sometimes the patient may have dissociative sensory loss. What is dissociative sensory loss? Let's suppose the patient is having only a lesion in this part, upper cervical cord, which will involve only this fiber, that is the spinal nucleus of the trigeminal nerve. Then the patient will have loss of only pain and temperature. But if you check for the pain and temperature, the patient cannot feel the pain and temperature sensation, but the touch fiber is upper in the pons, the central pontine nucleus. So the touch is preserved, but the pain and temperature is lost in this patient. Then we can assume that the patient might having some pathology in the lower part or the upper part of this cervical cord, or lower part of this brainstem. That means only the pain and temperature is lost, but touch is preserved. Definitely the patient will having some pathology in this part, the upper cervical or lower brainstem part. That is the dissociative sensory loss. Dissociative sensory loss means that the patient is having sensory loss, only pain and temperature is lost, touch is preserved in that patient, So this is the basic understanding of the trigeminal nerve. Remember, trigeminal nerve is a mixed nerve. both the sensory as well as the motor sensation via the ophthalmic, the maxillary and the mandibular branch, and motor via the motor root which supplies the muscle of the mastication, the temporalis, the masseter, the medial and the lateral pterygoid. The lateral pterygoid closes the jaw. You can see only the lateral pterygoid only opens the jaw, and all other closes the jaw, all other muscle closes the jaw. So, and remember the dissociative type of sensory loss, where there is only loss of pain and temperature in whole of the face, but touch is preserved. Then you can think of some pathology in the upper cervical cord or lower brain stem. If the patient is having onion peel type of sensory, only sensory loss is in this perioral region, and later on it is increasing with days, but the lateral part or the posterior part is preserved. That means onion skin type of sensory loss. Some pathology originating from the middle of the brain stem or the spinal cord, like that of syringobulbia, syringomyelia. So we shall suspect that pathology. And now let us come to this chart. This chart, we know that the sensory division we have discussed, that is the V1 ophthalmic maxillary, V2 and V3 is the mandibular division. So this ophthalmic division will exit the skull from the superior orbital fissure, maxillary division will exit the skull from the foramen rotundum, and mandibular from the foramen ovale, which will terminate into branches, the frontal, reclimer, nasociliary and meninges. So remember, trigeminal nerve not only carries sensation from the face, but it also carries sensation from the meninges. It also carries sensation from the meninges, the maxillary nerve also, the ophthalmic nerve also, the mandibular. That means the trigeminal nerve carries sensation from the dura meningeal layers, dura mater, and the ophthalmic nerve will terminate into frontal, lacrimal, nasociliary. The maxillary nerve will terminate into infraorbital, zygomatic, superior alveolar and pterygopalatine. Mandibular into buccal, lingual, inferior and auriculotemporal. So remember that trigeminal nerve carries sensory input from the face, from the meninges, as well as from the mucosa also. What mucosa? From the cornea also it carries sensation from the cornea, the sclera also, the cornea also, as well as from the buccal cavity also. It carries sensation from the tongue, the mucosa of the palate, everything it carries sensation. So you will think that how tongue carries sensation of the trigeminal nerve? Yes, it carries general somatic afferent sensation. We know that it carries general somatic afferent sensation, which means the touch, the pain, the temperature. It is carried by the trigeminal nerve. Taste is carried by the other nerve, but remember, touch, pain and temperature from the tongue, anterior 2/3 of the tongue, the other than the taste, that is the touch, pain and temperature, is carried by the trigeminal nerve. So ophthalmic division, I told you, supply the bridges and the side of the nose. They supplies the forehead, the upper eyelid. Its maxillary supplies the lower eyelid. Supplies the lower eyelid, the side of the nose, and mandibular division supplies the cheek and the lower lips, So these are the different supply of the ophthalmic, maxillary and mandibular division. So how do we examine the patient for a trigeminal nerve examination or cranial nerve fifth examination in the patient? We first examine the motor component. So we know that the motor component supplies the muscles of the mastication, the temporalis, the masseter, the medial and the lateral pterygoid muscle. So inspection, sometimes you may get a hollowing of the temple. This is your temple. So there may be hollowing of the temple, like that of in CLD patient, you get the hollowing of temple. That is because of malnutrition, bilateral hollowing of temple in a CLD patient because of malnutrition. Because of trigeminal nerve involvement also, you may get unilateral hollowing of temple because of lower motor type of neuron lesion. If the patient is having element type of lesion, then there will be muscle atrophy. We know that element, there is more of muscle atrophy. If you have seen the video lecture on the motor system examination. There also we have discussed that in element type of lesion there is wasting of the muscle or atrophy of the muscle more. So the patient may have hollowing of temple because of wasting of the frontalis muscle, wasting of the masseter muscle. The patient may have flattening of the cheek, flattening of the cheek on the one side. And the feature of element lesion is fasciculation, twitching. The muscle, individual muscle fiber, there is twitching, so it will move. That is the fasciculation. So on inspection you can see, first you have to inspect the patient. When you are asked to do a trigeminal nerve examination, examine the fifth cranial nerve of this patient. Then first you inspect the patient and look or say that there is no temporal hollowing, there is no flattening of the cheek, there is no fasciculation seen, there is no any abnormal movement seen. Sometimes the patient may have oropharia, dystonia, orofacial dystonia. There might be abnormal movement of the mandible, abnormal movement of the mandible. So this is on inspection you have to say this finding. Then you go to examine the motor system, motor component, and to look for the bulk of the muscle. We have already inspected for the bulk of the muscle, and to look for the power of the muscle. Powerful. So first command you give is, after inspecting the patient, you ask the patient to clench the jaw. Ask the patient to clench the jaw. So when the patient clenches his jaw, then you try to palpate the muscles. Try to palpate the frontalis muscle bilaterally. Then you place your finger on the anterior border of the masseter. So you place your, when you clench you can do with me, you clench your teeth, and the anterior border of masseter, you place your finger on the anterior border of the masseter. This is a masseter, and you clench your teeth. So when you clench your teeth, you see that your finger, after contraction of this masseter muscle, is moving forward. So you have to compare the forward movement of this finger. So if there is weakness on one side, your finger will not move forward. So in this way you get to know that there is weakness on the one side, there is weakness of the masseter muscle on the one side, and there might be problem in the trigeminal nerve in that side. So your finger move forward. So you look at the symmetry, whether both side is moving equally or not. So jaw deviates on the weak side. So I told you, if there is weakness on the right side, say suppose weakness of the medial and the lateral pterygoid muscle on the right side. So when a person will open his mouth, the jaw will deviate to the right side on the weak side, because there will be unopposed action of the normal side is working good. So function of the left side is to move the jaw to the right side, and function of the right side is to move to the jaw to the left side. Both is working in a synchrony in a normal individual, and jaw is in the midline. But if there is weakness on the one side, this muscle will have unopposed action, as there is no power on this side. So this muscle on the left side will push the jaw on the right side. So if there is weakness on the right side, the jaw will deviate on the right side. Also remember for the tongue. So if the patient asks the patient to protrude the tongue, this is for another example, hypoglossal nerve, we will discuss later, but the concept is same. So when the person protrudes his tongue, you see the tongue is deviated to, say suppose right side, then you assume that there is weakness on the right side. So tongue also deviate on the weak side, and the jaw will also deviate on the weak side. Remember, jaw will also deviate on the weak side. But the angle of the mouth in patient of stroke, will pull, normal side will contract and pull the angle of mouth to the same side, So the angle of mouth will deviate on the normal side, but jaw will deviate on the abnormal side, the tongue will deviate on the abnormal side. So remember, this is the function of the muscle, the anatomical organization of the muscle which decide the deviation. The function of the pterygoid is to normally to deviate on the other side. So the jaw is deviating on the normal weak side. The function of the tongue muscle is also to deviate on the other side. So if there is weakness on this side, the normal side will contract and deviate on the abnormal side. But the angle of the mouth, if the patient suppose having facial nerve palsy, 7th cranial nerve palsy on the right side, then the angle of mouth will deviate on the right side. Angle of mouth will deviate on the right side. But if the patient is having facial nerve, so if the patient is having facial nerve palsy on the right side, the angle of the mouth will deviate to the opposite side. Normal side will contract and will deviate the angle of mouth to the left side. So this is about the facial nerve, the angle of mouth deviating toward the normal side. But if there is weakness of this trigeminal nerve on the right side, then then the jaw will deviate on the right side. So remember, the angle of the mouth deviates on the normal side, the jaw deviates on the abnormal side, the tongue deviates on the abnormal side. So this is important concept, and this is definitely asked in your examination. Definitely it will be asked in your examination. Then you ask the patient to open the jaw, ask the patient to open to see whether there is any deviation or not. You ask to open and see whether there is any deviation of the mandible or not. Ask to protrude and retract also. Ask the patient तो अंदर की तरफ लेके जाओ, बाहर की तरफ लेके जाओ. Some patient may not do, but you may ask to protrude and retract the tongue. Cannot deviate the jaw on the opposite side of the muscle weakness, and you can see, you ask the patient to protrude to open the mouth, and you see the jaw is deviated on the right side. Then you assume that there is trigeminal nerve weakness on the right side. Ask the patient to deviate his jaw on the left side. The patient will not able to do, as there is weakness on the right side, and the function of the right side was to deviate the jaw on the left side. So the patient will not able to move his jaw on the left side if there is weakness on the right side and the jaw is deviated on the right side. So you can also check by placing a tongue depressor and asking the patient to bite, and you pull the tongue depression on the both side, and you can see that which side you can easily pull the tongue depressor. The side which you can easily pull the tongue depressor, you can assume that that side is weak. The person cannot hold the maxilla and mandible together to hold the tongue depressor. So unilateral weakness is possible if the patient is having any lesion in the brain stem, the trigeminal ganglia or the root. So if the patient is having problem in the root, in the trigeminal ganglia itself, or in the brain stem somewhere, if the patient is having problem in the brain stem somewhere, then you may get unilateral weakness on the one side unilateral weakness. Bilateral weakness, the patient is having bilateral weakness both sides. Patient will not able to close his jaw also. Patient will have difficulty deglutition also. The saliva will accumulate on the floor of the mouth. Difficulty deglutition of the saliva also. This page here, excessive saliva, not excessive saliva, but there will be saliva accumulating in the base of the floor of the mouth. The patient may sometimes will have a cotton placed in the floor of the mouth to soak that saliva when he visits your OPD. So the patient may have saliva accumulating, the patient may have difficulty deglutition, difficulty closing the mouth. Then this such scenario can occur in a patient of motor neuron disease, amyotrophic lateral sclerosis, motor neuron disease. Patient may have these symptoms where there is bilateral weakness. But remember, the upper motor type of this unilateral weakness is the element type of weakness, either in the nucleus, in the ganglia, in the root, element type of weakness. But say this is your nucleus, mesencephalic nucleus, pontine nucleus, and spinal nucleus of trigeminal nerve, and this is your cortex, and this is the right side mesencephalic, pontine nucleus, and spinal nucleus of trigeminal nerve. So we know there will be pair for the right side and for the left side, for the right side and for the left side. So remember, this nucleus will be supplied bilaterally from both sides, from the both the cortex, right cortex as well as the left cortex. This side nucleus will also be supplied from the both side of the cortex. So remember, the nucleus or the supranuclear connections are bilateral supranuclear connection. So if the patient is having lesion on the one side, say suppose one side, then upper motor type neuron lesion means above the nucleus, then there will be no deficit. Why there will be no deficit? Because the nucleus has a bilateral cortical innervation. The other side cortex is normal. Supply from the cortex from the other side is normal. So UMN type of unilateral UMN type of lesion will not produce any deficit. But bilateral UMN type of lesion can produce deficit. Bilateral UMN type of lesion, what disease can cause bilateral UMN type of lesion is the amylotropic lateral sclerosis. Amylotropic lateral sclerosis can produce bilateral lesion above the nucleus of the trigeminal nerve. So remember, unilateral UMN lesion, there will be no weakness, but bilateral weakness will present in motor neuron disease, that is amylotropic lateral sclerosis. Myopathy and neuromuscular junction disorder can also produce bilateral weakness. Myopathy, problem in the muscle itself. Neuromuscular junction like that of myasthenia gravis can produce bilateral weakness. So the patient has inability to close the mouth. If the patient coming with you with open mouth, don't think that it is tetanus jaw lock. Patient might have trigeminal nerve nucleus weakness also. Then you examine for the sensory system. After examining, inspecting the patient, commanding the patient to clench his teeth, palpating the muscles. Then third step, you look for the sensory symptoms. You look for the touch, you look for the pain, you look for the temperature only. So you can also look for the proprioception is very difficult, vibration, 2-point discrimination difficult, but in face at least you should look for the touch, pain and temperature. So where to look? You look on the face as well as on the mucous membrane also, that is the anterior tongue, anterior 2/3 of the tongue. The touch, pain, temperature supplied by the trigeminal nerve. Then the symmetry is more important. Suppose touch, I am checking for the touch for the ophthalmic division first. The touch, I will touch on the both side of the forehead and ask the patient, is it equal on both sides? The patient will say, yes, it is equal on the both sides. The touch is equal on the both sides. Patient say, no, I am feeling touch reduce on the right side. Then it's abnormal. The right side has pathology. Right side there is reduced touch. The right side trigeminal nerve pathology might be present. So similarly for the touch, pain and temperature, we will compare for the each division. For the ophthalmic division, we will look on the forehead on the both side and the upper part of the bridge of the nose on the both side. Upper part and the upper eyelid also you can look. And for the maxillary division, you look at the chin and the upper lips, and for the mandibular division, you look upper lip, the cheek and the upper lips, and chin and the lower lips for the maxillary division. Mandibular division. So ophthalmic division, forehead and bridge of the nose. For the maxillary division, the cheek and the upper lip. And for the mandibular division, the chin and the lower lips. So you compare all the sides, the V1, V2, V3, ophthalmic, maxillary and mandibular division. And never forget to compare the perioral region with the posterior face. So here it is no sensation. Here there is sensation present, but in the perioral region there is loss of sensation. So what is that condition known as? Yes, onion skin sensory loss. Then you should suspect there might be some pathology originating from the middle of the brain stem or the spinal cord. Spinal cord. And sometimes there might be dissociative sensory loss, as I told, pain, temperature preserved, but pain and temperature is lost, but touch is preserved. That is, patient may have lateral medullary syndrome. Lower part is involved. Lateral medullary syndrome. Pain and temperature is lost, but touch is preserved. Examination of the reflex. So after doing the sensory, first inspecting the patient, motor system examination, sensory system examination, and then you examine for the reflexes. What are the reflex which is involving the trigeminal nerve? The corneal reflex, the sneeze reflex, and the jaw jerk, sneeze reflex and the jaw jerk. There are other reflexes also, that is the head retraction reflexes, the zygomatic reflexes, the corneo-oculogyric, oculosensory, corneomandibular, nasal reflex, trigeminobrachial and trigeminocervical reflex. At least 1 to 2 names you should know, but you should never forget these 3 reflex: the corneal, sneeze reflex and the jaw jerk, which involves the trigeminal nerve, corneal reflex, sneeze reflex and the jaw jerk. Let us discuss one by one. First, let us discuss about the jaw jerk. So how do we do the jaw jerk? We place one index finger on the chin. We will place this index finger on the chin, and with patella hammer we will ask the patient to normally relax his mouth, open his mouth, and not open his mouth but just to relax his mouth in half open position, and then we'll place our index finger on the chin, and then we will strike on our finger. So in a normal individual, if the patient is half opening his mouth, keeping your index finger and striking, in normal individual there will be absent, there will be no movement, or there will be minimal active closure of the jaw. You can say little bit slight movement or slight closure of the mouth, or sometimes there will be no closure of the mouth, no response at all. And both, if no response is occurring or slight response is occurring, it is normal. Only abnormal is hyperreflexia, sometimes may be associated with clonus. If you strike, the patient may have hyperreflexia, sudden closure of the mouth, and sometimes clonus, that is up and down, open and close movement of the mouth, that is abnormal. So remember, abnormal is hyperreflexia, or increase in jaw jerk is abnormal. Normal is absent or minimally active. So this is the way we look for the jaw jerk, this is the way we interpret for the jaw jerk. And what is the reflex arch? Is the sensory division of, when we strike, the sensory division of the trigeminal nerve will go into the mesencephalic nucleus, and from the mesencephalic nucleus to the motor nucleus, and from the motor nucleus again motor division of the trigeminal nerve, which will contract the muscle of the mastication, and the patient will close his jaw. So both the afferent as well as efferent, both is the trigeminal nerve. So in jaw jerk, the afferent is the sensory division of the trigeminal nerve, and efferent is the motor division of trigeminal nerve. So both the afferent lobe and the efferent lobe is the trigeminal nerve only. So how to interpret normal and abnormal we have discussed. Now discussing about the clinical significance of this trigeminal nerve or trigeminal nerve test, that is the jaw jerk. So if the patient is having lesion above the motor nucleus, which means in the brain stem, we know that in the brain stem there is the motor nucleus, and from the motor nucleus motor fiber is going and supplying the muscles of the mastication. So, and the afferent loop from the mesencephalic nucleus is coming into the mesencephalic nucleus, and with the interneuron it will stimulate the motor neuron. So afferent is the also trigeminal nerve, efferent is also trigeminal nerve, afferent is the sensory division, efferent is the motor division. So if the patient is having any lesion above this motor nuclei, so normally we know that the upper motor neuron or the corticobulbar fiber. Why this corticobulbar is supplying the nucleus? So corticobulbar. If the fiber is going to the spinal cord, it was corticospinal, but the fiber from the cortex coming and supplying the nucleus of the cranial nerve. That is why this fiber are known as corticobulbar fiber. So if there is problem in the normally the corticobulbar fiber and corticospinal fiber are the upper motor neurons, and this normally inhibit the lower motor neuron, so it will inhibit this nucleus, it will inhibit this trigeminal nucleus. But if there is problem or the upper motor neuron lesion, the inhibition from the cortex is lost, inhibition from the cortex is lost. Now this nucleus will overfire, and the jaw jerk will be exaggerated. So remember, if the patient is having upper motor type of lesion above the nucleus of the motor nucleus of the trigeminal nerve, the patient will have exaggerated jaw jerk. So lesion above the motor nucleus of trigeminal nerve, exaggerated jaw jerk. What condition can lead? That is the pseudobulbar palsy or amylotropic lateral sclerosis patient. Again, in patient of amylotropic lateral sclerosis, there will be exaggerated jaw jerk. So you can differentiate it clinically. Say suppose the patient has presented to you with exaggerated ankle jerk, exaggerated knee jerk, plantar extensor, exaggerated biceps, exaggerated tricep, everything is exaggerated. Then you think that everything is exaggerated from lower limb, upper limb also exaggerated. Lesion might be somewhere in the cervical cord. That is why everything is exaggerated. Then if you check for the jaw jerk, and jaw jerk is also exaggerated, then lesion is not in the cervical cord only, lesion may be above the cervical cord or above the motor nuclei of the brainstem. So it is important way to differentiate the lesion, whether it is in the upper cervical cord, that is why the upper limb jaw jerks are also exaggerated, lower limb jerks are also exaggerated, or the lesion is above the motor nuclei of the trigeminal nerve, so that the jaw jerk is also exaggerated. So if the patient jaw jerk is also exaggerated, assume that the lesion will be above the motor nucleus of the trigeminal nerve. But if all the lower limb, upper limb jerks are exaggerated, but jaw jerk is normal, then the lesion is in the upper cervical cord. It is not involving the jaw jerk reflex arch, the motor nucleus of the trigeminal nerve. So this way we can differentiate. If the lesion is below the motor nucleus of trigeminal nerve, then jaw jerk will be normal. And what is normal? Normal is absent or minimally active. Then you can check for the corneal reflex. So we look for the jaw jerk, we look for the corneal reflex by cotton, a piece of cotton. We bring from the side, or bring from the down. Ask the patient to look distant, at a distant vision, look somewhere at the wall, and then you bring a piece of cotton and then you try to touch as the name is cornea, then you should touch the cornea, not the sclera. Touch the cornea and not the sclera, and the upper part of the cornea. So this is your cornea, this is your eye, this is your cornea. So touch the upper part somewhere, upper part of the cornea, because the lower part may be supplied by the V2. Sometimes, not all individual, but in some individual, the lower part may be supplied by the maxillary division. But the corneal reflex, there is involvement of the V1, the ophthalmic division of the trigeminal nerve. So touch with a piece of cotton on the upper part of the cornea. Patient is having infection in one eye, then use different cotton, not the same cotton. Use different cotton. Otherwise, you will spread the infection from one eye to the other eye. Use different cotton, and you touch the upper part of the cornea, and you look for the reflex. What is the corneal reflex? You will see that there is blinking of both the eye. You will see that there is, if you touch, there will be blinking of both the eye. So what is afferent and what is efferent? Cornea sensation, the touch, pain, temperature is supplied by the trigeminal nerve, the sensory division of face, whole of the face except for the angle of the mouth, that is the C2, whole of the face, the nasal cavity also, the nasal septum also, the nasal mucosa also, the cornea also, the sclera also, everything, the buccal cavity also, the anterior two-thirds of the tongue also is supplied by the trigeminal and trigeminal nerve, except for the angle of the mouth. And the tongue also, that is the general somatic efferent, the touch, pain, temperature, not the taste. The taste is not supplied by the trigeminal nerve. So the efferent is the V1, the efferent is the V1. So this will go, and it will, through the interneuron, it will stimulate the seventh cranial nerve, that is the facial nerve, and there will be closure of the eye. So the efferent is the trigeminal nerve, and the efferent is the facial nerve. Facial nerve, oculomotor oculi, the facial nerve. So it supplies the facial nerve for closure of the eye. So afferent and efferent we have seen. So let's suppose the patient is having a trigeminal nerve lesion on this side. This is the left side. Patient is having trigeminal nerve lesion on this side. So if I am touching my cornea, there is lesion on this side. So touch or the reflex will not be carried. So if I touch, there will be no blink. As the sensation is being not carried to the central nervous system. Reflex arch is not communicating. There is no sensation at all. So touching and not touching is the same thing. So if I am touching on the left side, patient is having lesion on the left side, I am touching the cornea, there will be no blink. At all. So in unilateral trigeminal nerve lesion, if I am touching on the side of the trigeminal nerve lesion, that is the left side, there will be no blink in both eyes. There will be no blink in this eye also, there will be no blink in this eye also. In normal individual, what happens? If I touch on the one side, both eye will blink. If I touch this side, both eye will blink. But in unilateral lesion, I am touching on the side of the lesion, there will be no blink as there is no input carried. To the central nervous system because of trigeminal nerve pathology. But if you touch on the normal side, say suppose patient is having right-sided trigeminal nerve disease, and you touch on the left side trigeminal nerve disease, and you touch on the right side. So sensation will be carried through the trigeminal nerve, that is normal, and will stimulate the facial nerve on the both sides. So there will be blink on the both side, on the affected side also and on the normal side also, because the efferent loop is the facial nerve. Facial nerve on this side is normal, only the trigeminal nerve is defective. So when you touch on the normal side, there will be blinking on the both sides. But when you touch on the abnormal side, there will be no blinking at all, because the input is being not carried. If the input is only gone, so it is not stimulating the bilateral facial nerve, so no blinking at all. But the normal side, the input is okay, it is stimulating the bilateral facial nerve, and bilateral facial nerve is normal, so there will be both sides blinking. So facial nerve is the efferent output, the effector organ, supplying the effector organ. So the blinking is the effector organ. So it will be normal. So what will happen if the patient is having facial nerve weakness then? If the patient is having facial nerve weakness on this side, it will touch on this side, this side. This eye will blink, but this eye will not blink. So direct reflex is absent. This eye, I am touching this side, weakness also this side, but this eye is not blinking, but this eye is blinking. Input is okay, it's looking bilateral facial nerve, but facial nerve on this side is effective. Facial nerve on this side is normal, so this side is blinking and this side is not blinking. And consensual, how? If I am touching on this side, if touching on this side, input is okay, it will stimulate the bilateral facial nerve, but the affected side will not blink. So you can see here in this chart, the patient is having facial nerve lesion, complete facial nerve lesion. So if you stimulate the involved side, so this side facial nerve weakness is there, I am stimulating this side will not blink, because the effector organ is the facial nerve, the effector organ is the blinking, so it will not blink, so that the blinking will be absent. But this side facial nerve is normal, so this side it will blink, If I stimulate the opposite side here, then this side will blink, but the effector organ is lost on this side, there will be no blinking. So remember the pathology of the corneal reflexes, if the patient is having pathology on the trigeminal nerve or the pathology of the facial nerve. So what disorder can affect trigeminal nerve? Patient can have weakness, motor system deficit. In patient of ALS we have discussed, patient of myasthenia, and sometimes giant cell arteritis. You may be confused with trigeminal nerve weakness. Giant cell arteritis or temporal arteritis, patient may present with pain in the masseter muscle along with jaw claudication, along with shoulder pain, body pain, tingling, numbness, unilateral headache with prominence of the temporal artery. On palpation, the temporal artery will be tender. Sudden unilocular loss of vision may be also present in some patients with headache. Then your diagnosis usually a old age female patient around 50 to 60, that is suggestive of giant cell arteritis, also having pain in the masseter and claudication pain while chewing. There will be pain in the jaw and the masseter muscle. This is how the patient of giant cell arteritis present to us, and we should not confuse it with trigeminal nerve disorder. So in ALS there is jaw drop. Patient is not able to close his mouth, dysphagia and excessive salivation on the floor of the mouth. We have discussed ALS is a disorder which affects both the upper motor as well as the lower motor neuron. So the patient will have hyperreflexia also, fasciculation also, wasting also, everything, both the features of. So if the examiner asks you, tell me one disease condition in which there is feature of both upper motor neuron also, lower motor neuron also. So that is the ALS. That is the amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis. Involuntary movement. Sometimes the patient may have involuntary movement oromandibular dystonias if the patient is having trigeminal nerve weakness, and patient may have trigeminal neuralgia also, pain, sudden wind coming, shaving, any trigger can cause sudden spasm which usually lasts for a few seconds, pain in a particular part of the trigeminal nerve distribution. It may occur because of the root compression by anterior inferior cerebral artery and superior cerebral artery, and sometimes it can also indicate dangerous condition like multiple sclerosis and acoustic neuroma also. So if the patient is presenting to you with trigeminal neuralgia, it is not difficult to diagnose trigeminal neuralgia. Usually the patient will come and you see that this part is not shaved, this part or a particular part is not shaved. So you ask why you are, and the patient is telling that I am having a sudden spasm of pain on my face here which usually lasts for around seconds, which usually lasts only for seconds, and this is triggered by wind or shaving or touching. So when you try to examine the patient, the patient will be hesitant, will not allow you to examine him or her, because by touching you can stimulate the pain. So, and when you see there is a part which is not shaved, or in female patient the part which is not having a makeup, so you can make a diagnosis of trigeminal neuralgia, and you can think it can be a benign condition also, like normally it can be compressed by anterior inferior cerebral artery or superior cerebral artery, the root compression, or sometimes it can indicate multiple sclerosis and acoustic neuroma. You have to take consultation, ENT consultation, and you can also examine the patient for other features of multiple sclerosis also, So this is the last image for the trigeminal nerve. You can see that this is what you notice, that the jaw is deviated to the left side. Can you see the jaw is deviated to the left side? So where is the weakness of the trigeminal nerve? It is on the left side, So we know that the jaw will deviate on the opposite of the normal side, or the jaw will deviate on the abnormal side. So if the jaw is deviated on the left side, weakness is also on the left side, or trigeminal nerve involvement is on the left side. So this is all about examination of trigeminal nerve and viva voice question discussion about the trigeminal nerve. Next we will discuss about the facial nerve.